Thank you very much once again for the kind introduction. I'm very happy to be. I'm not sure that you think it's all right that I'm up here again to speak for you, but I hope you can take it. I'm leaving for Copenhagen after this speak, so you will see no more of me. Sorry. Oh, good. And very much encouraged by Professor Hadget's. I'm already thinking now about a QLB 345. That was what he meant, wasn't it, Amit? Go on. Luckily for you, I will talk about the optimal analgesic block for total knee arthroplasty. But I don't really know whether I dare to open my mouth, because I saw Christian's presentation yesterday with all these tiny, very small cutaneous nerves. So Christian, bear with me. This is a little bit more simple, but it should be able to be performed, these blocks, by more people. But I greatly enjoyed your lecture. Thank you very much for sharing. And I still have no disclosures. Now, last year, late, we published this optimal analgesic block for total knee arthroplasty. I can say that we were the group of Dr. Benson, Professor Benson from Aarhus, the second biggest city in Denmark, Bernard Marigel from Innsbruck, Professor Vincent Chan from Toronto, and myself. We had been corresponding in letters in regional anesthesia and pain medicine about the bloody adductor canal. But of course, it's not bloody anymore, it's just a canal. So we were encouraged by Mark Cantoon from regional anesthesia and pain medicine to write a daring discourse. As many of you will know, this sort of topic, a daring discourse, have not been around in regional anesthesia and pain medicine for that long. And we took up the challenge, and we thought, well, we'll give it a go and try to give at least the best version we could give for interested readers. And so we tried to do a comprehensive analysis of the anatomy, not as good as Christian's, but close by Christian, and then trying to find out from the literature and from our own experience what we thought would be the optimal block or block combinations for total knee arthroplasty. And we were very lucky because in an editorial for that, Professor Bosat had he was very, very kind, saying it is a beautiful illustrated account of the innovation of the knee joint, a truly international group. Ask this issue whether there's a nerve block or combination of nerve blocks available, discovered or not yet discovered, for the management of post-operative pain associated with knee arthroplasty. And he has this great subtitle: how can we block the nerves that innervate the knee joint without blocking the nerves that innervate the knee joint? Basically, we all know that if you block the femoral nerve, the common obturator nerve, and the sciatic nerve proximal to the knee, you will not have any pain in the knee following a total knee arthroplasty. But that also will result in paralysis, the quadriceps muscles and the hamstring muscles. So the patients will not be able to ambulate. And since I come from this tiny country where also Professor Kellett lives, he has for 25 years now talked a lot about, you all know that, about enhanced recovery and fast-track surgery. So just to mention the word femoral nerve or sciatic nerve block to Professor Kellett, you are at risk of having your head cut off. So we are really trying to find out solutions that can still be practiced by regional anesthesiologists like ourselves, and at the same time allow the patient to ambulate. Yes, and this picture, Christian, is just to show you that I'm in awe of all the research you've done and all the very nice presentations. So the free advice already given here straight on early in the lecture is that we suggest that you should block the nerves in the femoral triangle. I'll come back to that later. And you should block the obturator nerve. And how you want to do that, that is open for discussion, but we will give you a few hints. At the end of the lecture, there will be an alternative to the direct block of the obturator nerve that we will very soon publish. It has been accepted. It will be in radial anesthesia and pain medicine. And but I will just leave you with that bit of thought that that maybe you would not like to block the obturator nerve, because then you would block the hip adductors at the same time. But we have found in a study, and I will get back to that later, that that does not hinder the people from ambulating. So we think it is a good choice. Anyway, let's go through this. When you have your surgeons performing a total knee arthroplasty, in 98% of the time, at least in Scandinavia, our surgeons perform a medial parapatellar arthrotomy. That means that they open the skin with the midline incision. Here's where the cutaneous nerves comes in, some of the cutaneous nerves comes in, and then they perform this medial parapatellar arthrotomy. Now, this involves some nerves, and you should be aware of which nerves are they. And at the same time, if for some reason your surgeon performs a lateral parapatellar arthrotomy on the other side, well, of course, you have to change your strategy. But I will stick to this particular procedure, the medial parapatellar arthrotomy, because you would have to worry about the infrapatellar branch of the saphenous nerve, the medial vastus muscle nerve, or it's also called the medial retinacular nerve, and the anterior branch of the medial femoral cutaneous nerve. There are bound to be other cutaneous nerves involved in this midline incision of the skin, but I will not go too much into that. So a femoral triangle block is a block in the femoral triangle. I used to call it, 5 years ago, a saphenous nerve block. You measure the distance here from the base of the patella to the ACEs, and at the midpoint, you use a linear transducer to localize the sartorius muscle here, the femoral artery, and anterolateral to that, you see the saphenous nerve. And we had, for a long time, actually been performing this, particularly for ankle surgery, in combination with a popliteal sciatic nerve block, and it works brilliantly. What we became increasingly aware of in the last 5 to 6 years is that there are also branches, small branches of the vastus medialis nerve. There can be 2 or 3 branches of those, and they travel in this fascial layer just under the sartorius muscle, delivering motor nerves to the vastus medialis muscle, but also sensory nerves are traveling here, because we have, all of us, become increasingly aware. Think about the PEX blocks, for instance, lateral medial pectoral nerves, that there's no such thing as a motor nerve. They are all mixed nerves. And this is sort of this kind of nerve, a mixed nerve. So there's sensory branches in that as well. So that local that we inject here, around 2 to 3 milliliters, if you increase that to 5, 6 milliliters, it will spread in this fascial plane. If you do not see a spread in this fascial plane to also anesthetize the vastus medialis nerve, you will then just redirect your needle a little bit and spray around these nerve branches. Now, this is a picture from this the publication 2016, and I took it just to show you what happens when you scan up and down in the thigh, on the medial thigh. Here you have the sartorius muscle exactly in the same position like I showed you before. It is the midpoint between the ACEs and the basis of the patella. Some people say this is where the adductor canal is situated, but they are lying through their teeth. This is absolutely not the truth. Below the sartorius muscle, you have the femoral artery, and here with the green arrow, you have the saphenous nerve, and with the yellow arrows, you have the branches from the retinacular nerve, the vastus medialis nerve. Going a bit further down the thigh, still on the medial side of the thigh, you will see that here the medial border of the adductor longus muscle intersects with the medial border of the sartorius muscle. So this is, per definition, the apex of the femoral triangle. Now begins the adductor canal, and not before. Not before. And here we're down in the adductor canal, and you can see now that the green arrow again, the saphenous nerve, has penetrated the vasto-adductor membrane, this double-layered structure that you may or may not can see here. It has pierced it, and now it travels outside the adductor canal. And finally, at the distal end of the adductor canal, you see that the saphenous nerve is now between the sartorius muscle and the gracilis muscle up here. This is where the division, where the infrapatellar nerve branch is setting off. And you see, most importantly also, that the femoral artery and vein dives deep to enter the adductor hiatus. Just like with the subclavian artery, when that dives deep to the first rib, it's the same tube, but it becomes the axillary artery. It's exactly the same with the popliteal artery. When it dives through the adductor hiatus, it's the same tube, but it becomes the popliteal artery. So this is at the distal end of the adductor canal. So this is at the beginning of the adductor canal. This is at the end of the adductor canal, about 8 to 10 centimeters long. So why is it, Jens, or this group that I am lucky enough to belong to, is it really important whether we block the nerves in the femoral triangle or in the adductor canal? And I think you know the answer to that already. Yes, we do think so. And why do we think so? If you look at this, this is another image for the paper we put out. This is a picture that shows the vasto-adductor membrane. And now, to confuse you a little bit, blue arrow is now this is proximal, this is caudate. The blue arrow is now the saphenous nerve. And as you can see, the saphenous nerve dives into the adductor, just under the vasto-adductor membrane. It penetrates the membrane and comes out on the other side. The vasto-adductor membrane is the roof of the adductor canal. And up here with the dark blue arrow, you see the vastus medialis branch coming, and it looks very much like it's accompanying the saphenous nerve inside the adductor canal, but it is not. It is not. The vastus medialis nerve is not traveling within the adductor canal. Here you see the same image again, that the saphenous nerve pierces the vasto-adductor membrane in its distal part of the adductor canal, comes out. But if you see up here, there you have, with the yellow arrow, you have the vastus medialis nerve, and it enters a separate fascial tunnel in the fascia covering the vastus medialis muscle. And when you dissect, when you open this fascial tunnel of the membrane or the fascia covering the medial vastus muscle, you see that the vastus medialis nerve runs on top of the roof of the adductor canal, and not within. So that is actually the case. And ladies and gentlemen, this is why we urge you to place your local anesthetic in the femoral triangle. Because then you would block at the same time both the saphenous nerve and the medial vastus muscle nerve, or retinacular nerve. If you do it in the true adductor canal, you will only consistently block the saphenous nerve. And as it happens, more and more we have come to believe that this medial vastus nerve is probably as, if not more important, for analgesia following total knee arthroplasty. This is just what I've said. Now, moving to the obturator nerve, this is Charlotte Runge, another one of our PhD students. She published also last year the analgesic effect of the obturator nerve block added to a femoral triangle block after total knee arthroplasty. She used a technique that was published in 2012 in Anesthesia Analgesia. And it was the ultrasonic guide obturator block, a proximal interfacial technique. This is just where you localize the, you start by looking at the femoral artery in the inguinal grease here. You localize, of course, the femoral nerve, and then you go with your linear transducer more and more medial. When you come to this very medial side, you identify the adductors, the adductor longus, adductor brevis, and further more deep, the adductor magnus. What you then do is that you track back laterally and focus on the pectineus muscle, as you can see down here. And then you tilt your transducer cephalad, looking more cranially. And now you will see that below the pectineus muscle, a new muscle comes out, which is the external obturator muscle, and a fascial layer between the pectineus muscle and the external obturator muscle. And you will also see the superior ramus here of the pubic bone. We followed the advice from this paper to inject local anesthetic in this thick fascial layer. And what you see then is that local anesthetic goes exactly where you want it to go, up into the obturator canal to block the common obturator nerve. So what we found, here on the left, you see this is the combination with the femoral triangle block together with an obturator block. In the middle, you have the femoral triangle block alone, and over here you have Lear technique and no blocks. And we found that with the combination of the two blocks, the femoral triangle and the obturator nerve block, they exhibited significantly less, presented with significantly reduced opioid consumption over this observation period, which was 24 hours postoperatively. And most importantly also, we had an assessment done by physiotherapists for all of the patients here, whether these people who actually had a blockage, of course, of a paralysis of the hip adductors, whether they had any problems to ambulate right after surgery. And there was no difference between these three groups. So we found that was quite a significant result. Now, another of our PhD students, Thomas Dahl Nielsen, has just also published this very, very recently, a cadaveric study of ultrasound-guided subpectineal injector spray around the obturator nerve and its hip articular branches. Now, Thomas here is primarily interested in hip analgesia after hip repair. But I'm taking this because, I'm showing you this paper because it very nicely showed that here you see the pectineus muscle. Here you have, deep down here, you have the external obturator muscle, and you inject local anesthetic deep between the pectineus muscle. We actually use an outerplane technique and inject a volume no bigger than 10 ml of local anesthetic. And what we found was that local spread consistently from the point of injection here up into the adductor canal to anesthetize all the way up here the common obturator nerve. So this is, of course, is good for analgesia after hip repair, because then you will anesthetize these medial branches from the obturator nerve that track to the medial part of the hip joint. But we have found that it is the easiest way to block both of the obturator nerve branches, which is, and they divide further down here, you can see there's an anterior branch and a posterior branch. Actually, it is the posterior branch that delivers in 95% of the times, it delivers the the knee genicular nerves. So that is probably the most important one, but we like to perform the other block, because then that enables us always to have local anesthetic to track up into the obturator canal, and we get 100% block success of blocking the obturator nerve. Now, two young and very skilled women joined Dr. Benson's group. Siska here is from Denmark. Van Yi Wong is from Singapore. She did a fellowship with Thomas, and Siska is going to be Thomas's new PhD student. And the two of them, were very much focused on the fact that up till now we had only used sort of external landmarks to define where is the adductor canal. Is it in the mid-thigh, or is it in the lower thigh, or where is it exactly? So what they found was that if you measure the distance here from the base of the patella to the ACEs and mark the midline here with red, when you then did exactly what we saw in the beginning of the talk, that you found you scanned up and down of the mid-thigh, and when you find that adductor longus muscle medial border intersects with the medial border of the sartorius muscle, this is at the apex. This is at the apex of the femoral triangle. So in every case of, I think, around 30 volunteers, they found that if you draw this line or mark this point in the mid thigh from the ACEs down to the base of the patella, that the apex or the beginning of the adductor canal is consistently further distally. Okay, so that is the way you use internal landmarks instead of external landmarks to find out where exactly is the adductor canal. And I hope I made it reasonably clear that if you block the saphenous nerve up here, you will also block the medial vastus nerve. If you block it down here in the adductor canal, you will not block the medial vastus nerve. So that is a loss for you. So that I think they did a very nice work with this paper. So my promise also was, what about future block combinations? And apart from the QLB 4, 6, and 7 that I'm promising ADMIR that I will certainly find, we think we have an idea of trying to block the popliteal plexus, where the genicular branches from the tibial nerve and the genicular branches from the posterior branch of the obturator nerve ramify around the popliteal artery in the popliteal fossa. The advantage of that, of course, is twofold: that we will avoid paralysis. No, we would avoid to give paralysis to the hip adductors, and at the same time we will anesthetize the genicular branches from the tibial nerve without affecting, hopefully, the sciatic nerve. So we performed another study, and you saw this picture before. This is exactly where we placed the block to try to have local anesthetic track to this popliteal plexus in the popliteal fossa. So, and you notice, you remember from before, exactly where the femoral nerve dives deep and enters into the adductor hiatus to become the popliteal artery. If you inject a small volume of local anesthetic, 5 to 10 ml of local, our hypothesis was that would track, that local or collar would track together with the artery down into the popliteal area, and where the genicular branches ramify around the artery, we would block this popliteal plexus. And as I said, it's not published yet. It has been accepted at Regional Anesthesia and Pain Medicine. Here you see, we believe for the first time, that you can see the dye has spread into the popliteal fossa, and Professor Marickel here is lifting up elements of this popliteal plexus. We believe it is the first time that has actually been photographed, as such, the elements of the popliteal plexus. And at the same time, look over here. The sciatic nerve untouched. In all cases we did this injection, the sciatic nerve untouched or unstained by the coloring at the same time. And obviously, and certainly not to pay back to Professor Hadgis a little bit, if you use a higher volume like they did in an excellent paper here in Anesthesia Analgesia 2016, where I believe they injected 20 ml of local anesthetic at the same part, that is in the distal adductor canal, just where the artery dives deep. They found a heavily staining of both the sciatic nerve and all over the popliteal fossa here. So that perhaps is because of the volume. We don't know, but it seems to me quite sensible to have a smaller volume injected in the distal adductor canal if you want to avoid the staining of the sciatic nerve. So basically, we believe that a take-home message for you would be to stick to small volume blocks, to block the saphenous nerve and the medial vastus muscle nerve in the femoral triangle. If you want to, you can certainly block the obturator nerve as a subpectineal block, or maybe if you want to, you can try to perform a low volume popliteal plexus block. Thank you very much for your attention.
So we could have whole symposiums discussing knee analgesia. So Jen's got to catch a flight home, but if we can have a couple of questions for Jen.
Everything is clear.
If no one's got a question, I think Dr. Hadzik alluded to standardised protocols for knees, which I think is certainly what many institutions obviously do already. So can I ask you, in your institution at the minute, what would you recommend for your routine knee arthroplasties?
For the routine, and if we should standardize at the present time, I would say a femoral triangle block, 5 to 10 ml of local, and then 5 to 10 ml to block the common obturator nerve. The popliteal plexus block is still has yet to be proven in clinical trials for randomized controlled trials. So that would be my answer.